welcome to our show, Health and Wellness Myths and Facts. I'm Ankita Mukherjee. The endocrine system is a network of glands that produce and release hormones. These are the hormones that are responsible for various functions in the body, from heartbeat to tissue growth to even the creation of new life. Diabetes mellitus is one of the most common endocrine disorders that affect the body's ability to produce or use insulin. And worldwide, 537 million adults currently live with diabetes. The number of people with diabetes in India is the second highest in the world. 74 million adults who live with diabetes in India. Now, those are really shocking numbers. The worst part of this is that diabetes in India starts at a relatively young age, almost a decade earlier than in Western countries. Early onset diabetes increases the risk of associated complications. And what can we do to guard against this? Well, educating ourselves and making sure there's better management and control of diabetes, of course, is one way to go about that. There are several misconceptions also about diabetes prevention and management, and it's only by making ourselves aware that we can help everyone else understand just what we live with. This is exactly what we hope to do in this program. Our experts provide medically accurate and actionable advice on both preventing diabetes and helping identify strategies for long-term control of diabetes. Joining us today, Dr. Parthapratim Chakraborty, Assistant Professor, Department of Endocrinology and Metabolism, Medical College, Kolkata. Dr. Professor Sholil K. Pal, Senior Consultant Endocrinologist with Divine Nursing Home, Suraksha Clinic, Kolkata. And Dr. Sunil Kumar Kota, who's a Consultant Endocrinologist, Diabetes and Endocare Clinic in Brahmapur. Thank you all for being with us. Let me begin with Dr. Chakraborty first. Diabetes, of course, a growing health concern around the world, but particularly in India, with over half the population at risk of developing the condition at some point of time in their lives, Dr. Chakraborty. So what are the reasons that type 2 diabetes particularly seems to be more prevalent in India? Dr. Parthapratim.
Right, you are absolutely correct as far as the figures are concerned. The most important thing I would say for Indians with diabetes, the high risk of diabetes is because of the genetic predisposition. We teach our students, and we have also been taught the concept of thrifty genotypes. Indians per se are more prone to develop type 2 diabetes in particular because of their genes. In addition, we know that we are rapidly growing economy. We have a rapidly growing economy, so there is rapid urbanizations. That ultimately leads to a kind of an unhealthy eating habits and the absolute lack of physical activity, if I'm not wrong. Particularly if you look at the children's, they don't do that much of sports, that much of physical activity nowadays. So these are in short, these are the major reasons of developing type 2 diabetes in India at a much higher prevalence compared to our Western counterparts.
Right. Dr. Pal, if I can bring you in also, what is secondary diabetes? Is secondary diabetes and type 2 diabetes the same? And what conditions can lead to the development of secondary diabetes?
Thank you. See, secondary diabetes and type 2 diabetes are not the same. Secondary diabetes is a type of diabetes that usually occurs secondary to disorders of pancreas, that may be fibrocalculous pancreatopathy or acute pancreatitis or chronic pancreatitis, or some drugs, commonest being the steroids, and it may be secondary to some disorders like Cushing syndrome, acromegaly. And management of secondary diabetes is usually with insulin. And secondary diabetes is that type of diabetes which may be aggravated due to presence of type 2 diabetes. And what is the third part of your question? Pardon me, madam.
Right. I was, in fact, asking you, Dr. Pal, the conditions that can actually lead to the development of secondary diabetes.
Yes. So conditions usually, I just told you that it is due to pancreatic causes like pancreatopathy or acute pancreatitis or chronic pancreatitis. It may be due to some endocrine disorders like acromegaly, Cushing syndrome, or Turner syndrome, or it may be due to some drugs like glucocorticoids, beta blockers, or even phenytoin sodium.
Right, right. Okay, let me bring in Dr. Kota as well. Dr. Kota, how does birth weight affect the risk of developing type 2 diabetes mellitus?
Ankita ji, it indeed is an interesting and intriguing situation as well, because the birth weight is having a U-shaped relationship with onset of diabetes in later life. Studies tell us that low birth weight, which is defined as birth weight of less than 2.5 kg, is associated with 22% increased risk of diabetes. On the other hand, high birth weight, which is defined as a birth weight of more than 4 kgs, is also associated with 19% increase in occurrence of late onset diabetes. You can see the high birth weight is an indicator of uncontrolled, undiagnosed or untreated diabetes or obesity in the mother, and this high weight can induce a state of insulin resistance whereby the body's insulin will not be able to discharge its normal duties of controlling the sugar. On the other hand, the low birth weight as proposed by this Barker hypothesis is an indicator of intrauterine undernutrition. This gives rise to defective programming of the neurohormonal circuits which are present in an organ of brain called hypothalamus, essential for appetite, body weight and metabolic control. If you see a low birth weight baby is subsequently subjected to neonatal overfeeding, that can give rise to diabetes and obesogenicity. So the public health importance is that if a baby is born low birth weight or high birth weight, in either case, you have to ensure that the baby is not getting affected with unhealthy diet, physical inactivity, and unfavorable body composition.
Right. Thanks very much for that. That was very clarifying. Dr. Chakraborty, let's, diversify this further and actually talk about symptoms also. Now, many people with type 2 diabetes are asymptomatic. When do symptoms actually start appearing in patients, and what form do they take?
All right, you are. The most important challenge we face, and my colleagues will also agree, that diabetes is basically an asymptomatic disease. Majority of our patients, they do not develop any symptoms as far as the high blood glucose are concerned. Now, if the blood glucose is significantly elevated, they may have increased thirst, they may have increased frequency of urinations, may have unexpected weight loss. These are the classical symptoms of high blood glucose, irrespective of etiology, be it type 1, be it type 2, be it secondary diabetes. But unfortunately, many of them are asymptomatic, and in majority, if not in majority, almost in half of them, we pick up diabetes only once some complications of diabetes has already set in. For an example, the organs which are much more important for diabetes in patients with diabetes are number 1, the kidneys, the number 2, the eyes, number 3, the nerves, and the heart and the brains. So having said that, all the organs of the body can be affected with diabetes, but to answer your question in a nutshell, majority of them are asymptomatic, may have unexplained weight loss, increased urination, increased thirst, increased hunger as well. If the blood glucose level is uncontrolled, is very high, may have repeated soft tissue infections like skin infections, may have genital infections, or may have some complications of diabetes related to eyes, kidneys, or nerve. These are the symptoms which I would say is important for an individual to know whether he or she has having diabetes or not.
Right. From symptoms to testing, Dr. Pal, if I can ask you this, what is the recommended frequency of testing blood sugar levels for newly diagnosed people with diabetes or patients who've moved on to new treatment plans? Dr. Sholit Pal?
Thank you, madam. See, this is a very interesting question in that way that there is no definite hard and fast rule that this frequency to be tested in a newly diagnosed type 2 diabetes or type 1 diabetes. See, as the type 1 diabetes are on insulin, so more frequent testing is recommended, and none of the academic bodies have given clear-cut recommendation that what frequency should be tested. But for better controlling of type 1 diabetes, it is better if the patient can test his blood sugar, especially on the capillary blood glucose testing of blood sugar, at least 3 to 5 times in a day. Best is 7 times in a day for the first few weeks of newly diagnosed type 1 diabetes. For type 2 diabetes, again, better to test 3 times in a week is adequate for controlling blood sugar. But if the patient is on some sulfonylurea or insulin, even in type 2 diabetes, more frequent testing is necessary. Drugs that do not cause hypoglycemia, say for example, metformin, DPP-4 inhibitors, flozins, dapagliflozin, empagliflozin, this group of drugs do not cause hypoglycemia. So those patients who are on this class of drug, less frequent testing of blood glucose is recommended, as chance of hypoglycemia is less or minimum. For my part, recommendation is also depends how much the patient can afford, what the health service facilities are available to the subject. So all these are related to the number of testing in the newly diagnosed type 2 diabetes or type 1 diabetes.
Right. Dr. Kota, can early short-term insulin treatment in people who've recently been detected with diabetes actually help to reverse type 2 diabetes, or is this completely irreversible?
Ankita ji, you would appreciate the fact that of late, reversal of diabetes has been taking the center stage of majority discussions.
Yeah.
But if you look at the scientific literature, we do not see much of evidence as far as usage of insulin in giving rise to reversal of diabetes. If you look at the national and international guidelines, we have specific set of conditions where we need to use insulin at the time of diagnosis itself, like whenever the person is having very high blood sugars like fasting sugar of more than 250, after food sugar of more than 350, or HbA1c of more than 9%. If the patient is having catabolic symptoms of weight loss, if he is being subjected to surgery, or he is undergoing a stressful situation like infection. Apart from that, just to take a case of type 2 diabetes, what happens here is that once the patient is newly diagnosed, the beta cells producing insulin are under stress. So when we give non-insulin medicines, we are asking the already stressed out cells to produce more insulin. So giving insulin briefly, it gives rest to the stressed out beta cells. It prolongs the life of the beta cells. And there is one interesting South Indian study which told us that if you use insulin briefly for about a period of 4 to 6 weeks, the beta cell function is there for a prolonged period of time. There is better glucose, and patient is also under diabetes remission. So it is always a welcome step to give the patient a better outcome in the long run.
Right. All right. Thank you very much for all of that. We will have to take a quick break at this point, but when we come back, a closer look at day-to-day diabetes management. We'll be back in just a moment. Welcome back to Health and Wellness, Myths versus Facts. We're talking hormones and diabetes and its management. Let's take this back to Dr. Chakraborty now. Dr. Chakraborty, are the targeted glucose levels for diabetes management different for different age groups? Does the presence of diabetes complications and other comorbidities actually affect these target levels?
Yes, absolutely. There I would say there are 5 or 6 points. For an example, it all depends upon the age of the patient. For an example, we opt for a somewhat less strict blood glucose level in infants, in children, or in elderly people. The targets depend also on duration of the disease, the associated complications of diabetes, the underlying comorbidities, the life expectancy of the patients, and as Professor Pal has already discussed, the frequency of hypoglycemia. For an example, someone who is 85 or 90-year-old having a long-standing diabetes with advanced renal disease, associated cardiovascular disease, with frequent episodes of hypoglycemia, we opt for a lesser degree of or lesser strict diabetes control. Because, if hyperglycemia or the elevated blood glucose level is harmful, so is hypoglycemia or the low blood glucose. So we always tend to avoid hypoglycemia as much as possible in day-to-day practice. So all depends upon these issues in a particular patient. It has to be individualized. There is no watertight criteria that this should be your target for all of your patients.
Okay, fair enough. Dr. Pal, what kind of complications does diabetes cause? Is it true that, some of these complications can be prevented or at least delayed? Dr. Pal.
Yes, diabetes is a disease that is specially known for its complications. See, diabetes, whether type 1 or type 2 or secondary, some complications may be acute, that is diabetic ketoacidosis, hyperosmolar coma, lactic acidosis. But chronic complications of diabetes are very specific, and as the patient suffers from diabetes for decades, these complications usually occur. This can be again are of two types, microvascular and macrovascular. That is to say that diabetes can affect retina, it can affect the nerves, it can affect the cardiovascular system, it can affect the kidney, it can affect the heart. So these complications of diabetes, that is retinopathy, nephropathy and neuropathy, very much specific for diabetes, and that cannot be prevented altogether, but that can be delayed for years by strict control of blood sugar. Especially, it is seen that if we control the diabetes for first few years of diagnosis of diabetes, then complications can be prevented for decades. But duration of diabetes and whether the diabetes is totally uncontrolled with very much elevated or very low blood sugar, then complications occur earlier. So that is totally cannot be prevented, but we can certainly delay the complications of diabetes.
Okay. Dr. Kota, what about blood sugar control? Is that by itself sufficient for the effective management of diabetes? What other factors need to be controlled?
Yes, actually, see that diabetes is like a Pandora's box. It is not only about elevated blood sugars, it also gives rise to other conditions like hypertension or high blood pressure, dyslipidemia or high cholesterol levels. And the goal of management is to not only control the sugars, but also to give the patient a complication-free life. The complications have already been wonderfully alluded to by Professor Pal. But then you have to control the sugars, you have to take care of the blood pressure, you have to take care of the cholesterol, you have to keep your weight under check, because it is stated that if the weight is gaining at the cost of reducing blood sugar, probably some of the benefit that you are losing out. Apart from that, you have newer drugs in your armamentarium which not only controls the sugar but additionally controls the blood pressure, cholesterol, and gives protection to all the organs those are affected by diabetes. And very importantly, I would like to add here that all the complications highlighted by Professor Pal have to be screened periodically from the diagnosis itself so that they can be picked up early, and we have drugs to get them back to normalcy. So holistic approach and control of blood sugar, pressure, cholesterol, and ruling out complications would be the way to go forward.
Okay. Let me bring in Dr. Pal once again. Are people with diabetes more prone to other illnesses like colds and other infections?
Yes, very interesting questions. Especially we have seen that in the COVID pandemic, diabetic subjects has much more mortality. And even the H1N1 pandemic or epidemic, you can call it, of 2009, hospital admission due to cough and cold and pneumonia were triple or 4 times than usual during that period. That shows that cough and cold, respiratory problem, pneumonia, bronchopneumonia, pneumonitis are much more common in diabetes. This is because diabetes is a disease that causes immunodeficiency or immunomodulation. Both the cellular innate immunity and hormonal immunity are decreased in diabetic subjects, and they suffer from not only chest infection but also infection of the skins, infection of the genitourinary tract. Fungal infections especially are much more common in diabetic subjects, especially those who are uncontrolled. You know, some infections like abscess, carbuncle are very much prevalent in uncontrolled diabetic subjects. Not only that, diabetic subjects, when suffer from any sort of infection, they usually require much higher potency of antibiotic and in longer duration.
Right.
So, yes.
All right. Dr. Chakraborty, a quick addition to this, anything that you'd like to add to what we've already heard? Is vaccination against flu therefore a must for those with diabetes? How do they sort of try and prevent if they're going to be particularly prone to illnesses like colds?
They have to follow the typical adult immunization protocol. It's not specific for diabetes.
Okay.
As they are more prone to develop severe forms of disease, so they have to follow the immunization protocol for adults. That's applicable for all of us.
Right. Dr. Kota, quick last thoughts on this?
Yeah, absolutely. I would agree with Professor Pal and Dr. Partha. Immunization is a very important program, and now that COVID has wrecked the system, we all have to take the initiative and vaccinate all our diabetic patients with influenza. We have hepatitis B, pneumococcal, and several other vaccination programs routinely.
Right. All right. We'll leave it at that today. Thank you all for joining us in this very informative discussion. Thanks for watching.